Hey, this presentation is my version of comprehensive ultrasound physics with some knobology. We're going to go over a whole spectrum of ultrasound physics, including the physics of Doppler. Essentially, if you can master the physics of ultrasound, the only thing that will really trip you up is abnormal anatomy. This is going to be a really in-depth, really formal ultrasound physics. This is not entry level. This is not, for people just beginning ultrasound. This is, really in depth. You need to understand these levels of concepts if you really want to master ultrasound. It's really going to be helpful for, going into fellowship if that's your desire. If you're going to sono games, this is really what you need to understand at like the very base level of ultrasound and physics. So in the most basic sense, ultrasound is just the reflection of sound waves off of a structure, and it's highly dependent on the density of the medium that it travels through. The sound waves generated from a source propagate through a medium through compression and rarefaction or expansion of the molecules of that medium. So sound waves travel exceptionally well through water or liquid mediums and without any reflection back to the source. And this is how whales and other sea animals communicate over extreme distances. And that's why bats can only do sonar over short distances. Air is not as dense as water. So since sound is generated through the molecules in the medium by compression and rarefaction, air being less dense than liquid or solid material, sound waves do not transmit very well. The lower the density allows for greater compression of the molecules, such as in scuba tanks and firefighter breathing apparatus and compressed air tools. But remember that water and other liquids are nearly incompressible material. So this is why hydraulic tools, pictured on the right, are capable of very powerful work. The density of the liquid makes the transmission of energy possible, and sound waves are one form of energy. So energy is neither created nor destroyed. It is only transformed from one form to another. Sound waves can create mechanical energy, thereby heating up the tissue. And every machine, every ultrasound machine, should tell you the mechanical index or the mechanical properties of the frequencies and the thermal index or the frequency's ability to generate heat in a tissue. So let's talk about these mechanical and thermal effects of ultrasound a little bit further. Ultrasound is not entirely benign, and it's important to understand that these are theoretical risks. Before I became a doctor, I was a firefighter. More specifically, I was a fire engineer was my title. So this is where firefighting and ultrasound physics for me come together. Because if I had a big house fire and I had a water supply that was not giving me enough pressure, my pump would still put out whatever pressure I told it to. So if there was less pressure coming into the pump than I'm putting out of the pump, that becomes a negative pressure, a low pressure system. You're basically sucking water from the supply hose into the pump. That generates a lower pressure. The pump is working harder, it's spinning faster. That generates heat. That heat is transmitted to the water that it loves to absorb, and it'll lowering the pressure lowers your boiling point. You'll quickly start to notice bubbles being drawn out of the fluid, and as soon as they hit a cooler temperature or a higher pressure, they collapse. And that collapsing of the bubbles is called cavitation. This is a picture of a impeller from a pump as a result of damage to cavitation. So now imagine you're doing ultrasound on somebody's eye for a long time, and you start creating a lot of mechanical energy and thermal energy. You're going to start creating microcavitation. It's the same principle that we don't use Doppler, we don't use high energy on fetuses because surrounding amniotic fluid will absorb all that heat and mechanical energy, possibly create bubbles and collapse with cavitation, resulting in damage to the tissues, to the fetus, whatever. So these are the principles that are theoretic, but you need to understand that this is why we are cautious with who we do ultrasound on, and the ALARA principle, or as low as reasonably possible, or reasonably acceptable for ultrasound. We don't want to cause harm to the patient just trying to get a fetal heart rate. We don't want to hold the probe on their eye for long periods of time trying to decide, is that drusen or is that palpal edema? We want to be setting up our machine with the proper frequencies and probe settings in order to not cause cavitation and damage to the delicate structures. So let's talk about the anatomy of the probe. So our transducer has a basic structure like this. There's a plastic housing that has all these expensive materials in it, the most important being the piezoelectric element. This is what sends out the ultrasound waves. And usually this is all protected and very delicate. This is the most expensive part of the machine because it's so important, so vital. A bunch of science happens, and that science is what we're going to get into in just a little bit. But basically, a beam comes out. A primary beam is sent out from the transducer. So the angle of inclination is the angle at which the probe leaves, or the beam leaves the probe. And it usually is pretty wide, and it comes down to a focal point. And then at the side, coming off of this, there are side beams, or side lobes. So we call the structures nearest the probe the near field, and those beyond the focal point, the far field, with our focal point being just like our eye's focal point. So patients that are nearsighted, the focal point is ahead of the retina. Those that are far-sighted, the focal point is beyond the retina. So we use corrective lenses to change that angle or that point by refracting light so it hits our retinas at the right location to be the most precise. So this, of course, is over time. So waves get sent out from the probe and travel over time. They will hit structures. They will go through structures. Some of them will bounce back to the probe at different times. And that's the, up and down area on the machine. So even though we think about the beam coming out of the probe as, this small credit card beam that's very precise and in line, when in fact it's really more like this. We can't control the sound waves like we can control a laser beam. We can't pinpoint exactly where we want to direct those waves. So yes, there is the main beam, but unfortunately the other side lobes, the beam width, these other concepts, they radiate outwards. And the machine does the best it can to avoid those other errant or abnormal frequencies or signals. But again, it's not a perfect machine. Sound will travel outward in kind of a circular pattern like we see with waves on a pond. So I found these images through Radiopedia, a great resource for ultrasound-related findings and artifacts. And this kind of shows a good 3D representation of these side lobes. They reflect outward from the central beam. And as the ultrasound crystals expand and contract, the primary beam goes in the direction that it's supposed to, with these secondary beams kind of radiating in a circular fashion outward. They're called side lobes, and they're usually a low intensity beam that surround the central beam, but as they hit echogenic structures, they can reflect from neighboring structures and look like something is in the central field when it's really a side structure. So looking in the bladder, you may see something like inside that may look like sediment, but even though it's something outside of the bladder because it's the side lobe, the machine assumes, oh, well, that came from the central beam, so it must be here in the center of the image. So we've discussed the rarefaction and compression that happens when wavelengths travel through air. We've talked about, the possible complications of the transfer of energy from one form to another, and the possible effects of that. But what is a frequency? What is a wavelength? We really need to understand this in more depth to understand which probe selection we use when we're looking at a structure. So we measure wavelength as a measure of distance, and that can be from peak to peak or from trough to trough. It doesn't matter. So wavelength here is much shorter. So the wavelength from peak to peak is half of what this is. So peak to peak. And we use frequency as the measure of how many cycles per second. How many times does this go from peak to peak or trough to trough per second, cycles per second? So we use the term lambda to describe the measure of distance or time for the wavelength. So each cycle is how many times it travels through peak to peak per second. And this wavelength here is longer than this wavelength here. This is much shorter. This is more cycles per second. So this one's 3 hertz. This one's 6 hertz. This one's double that. So 12 hertz. 12 cycles per second. The number that we're using, the units of measure for ultrasound is much, much higher. We're talking in megahertz. The difference is amplitude. So these two wavelengths, these two beams, have the same frequency. The time or distance from peak to peak are the same. The only difference is the amplitude. From peak to trough, this one is much greater than this one here. So a higher amplitude, when we think about it, is going to be a louder sound. This is how loud the signal is. So if we want something to penetrate deeply, we may need a louder or higher amplitude signal, and we need a longer wavelength. So our wavelength determines resolution. When we learned about the electron micrograph, or when we learned about light microscopy in undergrad, we talked about the resolution, the ability of light to distinguish between two structures. Wavelength is the same thing. Ultrasound resolution is how well our ultrasound frequency can resolve or notice the difference between two structures. So let's say we have one object here and here. This wavelength can determine that there's one structure there, one structure there. So that's appropriate. If it's a smaller wavelength, we can put smaller objects in there, and the wavelength will hit one object and a separate object. So let's say that we're using a higher frequency probe or a lower frequency probe. How will that affect the structures that we can resolve? How will that affect the ability of the machine to detect the differences between muscle layer, fascial layer, bone, or between liver and gallbladder or liver and kidney? So each of these abilities is determined by the frequency. So if we have a lower frequency, we'll start with a higher frequency. If we have a higher frequency probe and a larger object, we can easily resolve those two images. So you can use a linear probe with a high frequency and resolve just about any structure, but because of the amplitude or the ability of that probe to penetrate through, or that wavelength to penetrate through, it can't go very deep. So sure, we can measure large objects and it will resolve them very well and you'll see very fine detail. But let's look at the opposite. If we have a curvilinear probe that is a low frequency, regardless of the amplitude, we can't distinguish if this is one object or two objects. The machine is just going to say, there's something there, but I can't quite resolve whether it's two images or it's just one. So each probe has a footprint or a beam configuration. It has a frequency range, high frequency, short wavelengths, or more cycles per second that are better at resolving smaller structures, but they can't penetrate as deep. Low frequency, longer wavelengths, less cycles per second, but better at penetration, depth, and distance. So if we think about pre-hospital providers, they use radio communications. Your car radio works the same way. It has an antenna that receives radio wavelengths, radio waves, through the air. And if we look at the different types of radios, so like a giant ham radio, so this is very low frequency, but it can travel a great distance. The quality may be really poor, but if you're not wanting quality, you want distance, this is the way to go. It's kind of like your curvilinear probe. It's like, well, I got a really fat patient. I need to see down through a lot of tissue. I may need to use a curvilinear probe, to see big structures. I don't want fine detail. I need big picture. As opposed to ultra high or very high frequency radios, these are good for very short length or short distance communications where you want good, clear communication. When as a firefighter, we used ultra high frequencies, radios that required a lot of repeaters so that good, clear communication could be had, but I didn't need to communicate with people in other cities or out of state. I just needed to communicate with my crew on the fire ground so they had good, clear communication. High frequency, low distance, but nice, clear, crisp communication. So by this point, you should know the average speed of ultrasound waves that travel through a tissue is 1,540 meters per second. That's an average of like all soft tissue. There are times when that speed is higher or lower, depending on a lot of different factors that we'll talk about in just a little bit. But this should be drilled into your brain. The speed of ultrasound waves in a average soft tissue, 1,540 meters per second. So if I haven't driven it home, it's almost a requirement to be really nerdy about ultrasound physics in order to be successful matching into ultrasound fellowship and being successful in ultrasound fellowship. So we're going to get like really nerdy. When we're talking about the Doppler principle, back in the mid 1800s, there was a guy, his last name was Doppler, and he figured that there is an apparent change in frequency when there's a difference in the relative motion between the source and an observer. So depending on the direction of motion, there will either be an increase or decrease in the frequency. So we use the probe as our source and the observer of sound waves. Like everything has to be done through the probe. The machine has to do all things. It has to send out a frequency. It has to also detect the relative differences in velocities between things. And then it has to also hear that and interpret it. So we use these variations in frequencies to our advantage. So in this picture here, we're measuring the velocity of red blood cells as they travel through a blood vessel. There is a relative difference in the velocities of the red blood cells when we compare it to the velocity or frequency of the probe sound waves coming out of the probe. So notice that the pulsed wave, actually the color Doppler box is tilted. This is called steering. So these machines are smart enough that the beam just doesn't come just straight out of the machine. We can send them out at a certain angle of inclination. We can adjust that. And we can throw on a color Doppler box that is in an appropriate orientation to detect whether there is a flow or a difference in velocities between the probe and something inside a vessel. So it's really simple. The relative difference in frequency or velocity inside the box, that's the observer or the listener in relation to the probe frequency or the source. So the angle of inclination coming out of the probe is, drawn on as this beam here, because it matches this box. We steered the beam to go this way. The direction of the flow of this blood vessel is this line here. So we need to make sure that our angle of inclination is less than 60 degrees to the angle of flow of whatever structure we're evaluating. So whether we're using an ultrasound probe or we're using a handheld Doppler like vascular surgery carries around, we have to utilize the same principle. We have to drop the angle of the listening beam so that it is less than 60 degrees, so that anything that's coming this way hits this line and can be detected. So real simple things: blue away, red towards. So in this image here, we have two different colors. So we have blood flow through a structure, blue away, so that means it's going away from the probe in this direction, and then red towards. Flow is coming this way towards. It's coming away from the this angle of inclination here. So the flow is coming away from the probe or away from the angle of inclination. Flow coming through this vessel is coming towards this inclination beam or line. So anything coming towards this line is going to show as red. Anything moving away from this line is going to show as blue. If we wanted to invert it, the machine will have a button that we just say invert, and this will change to red, this will change to blue. The color doesn't matter. It's understanding the concept of what's going away from this inclinating beam, what's coming towards this inclinating beam. And usually it's pulsatile, usually it's non-flow or a steady flow when it's venous. But there can be reversals, and there can be other things that will try to trick us. So we have to understand, well, this is, flow coming towards, and I'm, on their upper extremity, and it's coming towards my angle of inclination, so that's going out towards the hand. That's going to be away. I don't care what color it is. I just want to know what it's doing. So the other thing we have to think about, or the other concept of this, is the Nyquist limit. So on here we have a relative scale showing, let's say that this is the probe here. So anything going away from the probe is going to depend on the velocity. So low velocity, higher velocity, extremely high velocity. Going away from the probe, low velocity, higher velocity, extremely high velocity. The Nyquist limit is the maximum velocity that the probe or the machine can detect and measure before you get aliasing. Aliasing is when the blood flow, the velocity exceeds the Nyquist limit. And it'll be this mixture of this very high red or yellow. It's not like a mixture of like this and here. It's the very ends of the spectrum, because this can detect up to this point of velocity flow on these settings. So we can use that aliasing Doppler effect to our advantage in some instances that we'll talk about in just a little bit. All right, so we're finally into this presentation. It's only been 30 minutes. Now we're getting our first live views. So here's an example of aliasing. So whenever there's a narrowing of the lumen, we need to look at the flow through it. And so we just use a color Doppler box shown here. So if we see something that looks abnormal, a thickened or sclerotic aortic valve, or even a valve that's not moving that freely, we can put a color box on it and evaluate the flow through there. So this very bright area going through the center of this aortic outflow is very bright. The machine cannot detect the speed of the flow at that point. So it shows that it's this mixing of colors, very bright blue, very bright yellow. So just like pumping on the fire ground, if I needed more water to the fire, I had to change the velocity and pressure going through that hose. The heart has to do the same thing here. Anytime there's a narrowing of a lumen, the heart has to work harder to push the same amount of fluid to perfuse the body. So fluid has to flow at an extremely high velocity, and the machine may not be able to determine that, and we'll have this very bright aliasing to show us that. So we can use this artifact to our advantage. So we have a couple of concepts that we have to add on to this. We have acoustic impedance and we have attenuation. So impedance is the amount of resistance encountered by sound waves in different tissues. As the density increases, acoustic impedance increases. Or we can say it, sound waves don't pass through them as easily. But those dense tissues will readily absorb those frequencies, those sound waves. Attenuation, as kind of shown here in this ballistics gel, is the loss of wavelength amplitude, but not frequency. The frequency is still the same, but the amplitude gets lost over time or attenuated. Just like when we do a live attenuated virus, it's the same thing, it's just not as much of it. So, like before, the law of conservation, energy cannot be created or destroyed. It can only transform or be converted to other forms. So tissues absorb the ultrasound waves as different forms. This can be mechanical energy, this can be thermal energy, and it results in reduced amplitude. So if we look at it, this frequency is still the same the entire way. It's just as it goes deeper into the structure, it gets less and less. So the deeper it goes, the harder it's going to be for those sounds to bounce back. Because if something at this amplitude hits a structure and bounces back, it still has to go through all this tissue as well and may not even register because it's lost in the machine. So there's a spectrum of tissue impedance. In air, there's very little resistance. There's almost no resistance. So sound waves will travel through them without any loss of signal. The resistance is almost nothing. And then as we get more dense, water is obviously more dense than air. It's nearly incompressible. I don't know if you saw earlier, but the amount of force it takes to compress water by 1% is something like 17,000 pounds. It's an incredible amount. And then we have bone, one of the densest materials that we will ultrasound. So the propagation of sound waves through this medium, requires a level of high amplitude. So we don't need much energy to get through air. We need a little bit more to get through water, but it also transmits very well through water. But once it hits bone, the amount of resistance it reaches is really, really super high. But then again, it vibrates and it absorbs all that energy very well. This is a great example of what it looks like on ultrasound. So the sound waves going in and the signal returning through each one. So going through a fluid, there's very little loss of amplitude. So the acoustic impedance is very low, and it shows up as an anechoic image, right? There's nothing to bounce off of and return. So really there's like next to nothing. This shows a little bit of signal returned, but this is truly an anechoic structure. There's no return signal through that really. So soft tissue is a little bit more dense. So we have some acoustic impedance. So we have a lower signal coming out of the tissue. And so it has kind of this grayscale isoechoic. Once it hits the structure and returns, about the same. So let's look at fibrous tissue, more dense. So like fascial layers that are, the diaphragm and other things that are a little bit more dense and fibrous. You have a bit more loss of acoustic impedance, or a lot more acoustic impedance, resulting in a loss of energy, and it's highly reflective. So you're only losing a small amount going through the tissue, and it's highly reflective, so a lot of the signal returns. Now let's look at bone. Bone's very, very dense. It's a solid organ, very densely compacted, especially live tissue full of red cells, marrow, everything. So everything that hits it will vibrate through and bounce right back. Nothing will be shown beyond it. So the machine says, well, nothing came back in this time frame, so there must be nothing there. All right, so on to the orientation or geography of the screen. So let's say we're looking at someone's lungs, and we're trying to figure out, what's going on here. So our probe indicator is going to be on this side of the screen or this side of the screen, depending on what we choose. Every probe is going to have a dot, a marker, an elevation, something to indicate that that side of the probe is this side of the screen. It doesn't matter how you orient it, you just have to know how to read it. So we always consider this the near field. We always consider this the far field. So out of normal nomenclature of ultrasound, the probe marker, this here, the dot on the probe, is pointed to the patient's head or to the patient's right. When we get to the posterior side of the body, we just flip it. We point it to the left, because everything goes around the body, around the left side, across the front side, over to the right. Everything over here either points to the feet or to the patient's left. This is always going to be, not always, the near field is either going to be anterior, it could be right, it could be left, depending on what view we're in. If we're transverse on the anterior portion of the body, then we're looking from anterior to posterior. This is just a matter of time or distance. So this says posterior or left. If we're looking coronal in a fast view of the right upper quadrant, this would be the patient's right side. This would be midline towards the patient's left. If we're in the left upper quadrant, looking coronal, we're still going to be towards the patient's head, but now this would be the left side of the body, looking towards the midline to the patient's right, not the left. So it's important to understand what all the knobs and buttons of your machine do. And every machine and manufacturer are different. So the GE Venue Go has no knobs, no buttons, no dials, no sliders, nothing. It's all touchscreen, 100% digital touchscreen. So you just have to know the location of everything. And this is how the GE Venue Go is set up. So your pulse wave Doppler is here, your color wave here, your M mode here, your B mode, or your kind of home button here, and then you're going to have a store feature, you're going to have a freeze feature, your depth and gain, which if you look over here, this is the depth, this is the gain. And on these screens, if you wanted to increase the gain, you would tap here and slide your finger up, and that would increase your gain. If you wanted to lower the gain, you just do the exact opposite. You tap here and drag your finger down to lower the gain. If you wanted to do the same thing with the depth, if you wanted to get more depth, you would tap here and raise it up, I think. I'm not 100% sure. You adjust the depth by dragging up and down. It's kind of like your mouse on your laptop or your actual like physical mouse. Depending on how the machine is set up, raising this up may decrease your depth, and then dragging this down may give you more depth, or vice versa. Just depends on how the machine is set up, and I can't remember off the top of my head the direction for depth. Your frequency, you can change your frequency of the probe. So if you wanted higher resolution, even though it's a curvilinear probe, let's say they're a really thin person and they don't have a lot of depth, you can change your frequency to get better resolution, higher frequency, even though it's a curvilinear probe. Your time gain compensation, or TGC, you can adjust your gain generally by adjusting here or by using your gain setting, or you can change your time gain compensation. So this will change the gain based on which level you want to adjust. So you don't need a lot of gain up here close by because there's little impedance, there's little attenuation of your signal. But as you get down here, you may lose a lot of your signal, and so you want to add more gain to these further structures down here. One general thing that sonographers do is they put their time gain compensation, the actual sliders, and they'll start them here on the left and do kind of a diagonal down. So low gain, medium gain, high gain, so that at the depths at the farthest end, you're adding gain, you're adding amplitude to your signal to try and help visualize everything better. Let's take a look at some other manufacturers. So the Sonosite PX is kind of a hybrid model, and you may see this at other places that you work. You may see this at Sonogames, or when you see a rep who's trying to promote their product. So this is a combination of touchscreen and physical dials. So you would turn on color mode, or M mode, or Doppler, or you would go back to regular 2D or B mode. Anytime you want to freeze something, look for a snowflake. Anytime you want to take a still image, look for a camera. If you want to take a video clip, look for a video camera. So here's your touch screen trackpad, which you may, if you turn on M mode, it's going to give you a line down the center. And so you may need to adjust that by dragging your finger side to side. Changing your depth is just simple buttons, click buttons. But here you have your gain. So you do this kind of like an old school iPod. You would turn the click wheel up here to where it's higher gain, or you would decrease it by going counterclockwise to where it's lower. Or you can turn on your time gain compensation, TGC, by this value here. So measuring things, you would have to select your caliper or calcs, and if you wanted to label something, you would have to press the ABC button. A lot of times on these machines, your measurement that you want to measure may not come up right away if you're not in the right mode. If you're trying to measure EPSS and you don't have M mode turned on and active, when you hit calcs when you're frozen, you won't see anything to measure EPSS. Same thing goes for determining any kind of aortic velocities or pulmonary velocity acceleration times. If you're not in Doppler mode, you won't be able to measure it. So understanding where these modes are is determined by each machine. On the GE Venue Go, you have a separate button or touchscreen for pulsed wave Doppler and continuous wave Doppler. Whereas on the Sonosite, you have a single D for Doppler. Then you would have to come to your touchscreen up here to choose your option of, do I want pulsed wave or do I want continuous wave Doppler? It just depends on the machine. At Sonogames, you're going to encounter a range of machines. You may not see any GE Go's or Venue Go's. You may see some Sonosites. You may see some other GEs that look more like the the machines the sonographers use that are have a lot more bells and whistles and dials and buttons. So if you ever need to, just ask and somebody will point them out. All right, I promise we're getting close to the end. We're going to start talking about how the machine helps us, and we're going to first talk about gain. So we can either turn up the gain or turn down the gain. All that this does is it adjusts the sensitivity of the machine to allow for loss of signal. So if you don't have good contact with skin, or if you're trying to look through like very dry or dense material, you're going to have a lot of attenuation. You're going to have a lot of loss of signal going into the tissue. So everything's going to look dark, because once you lose signal, you can only evaluate the tissue by the returning echoes. So if you lose signal and everything looks dark, you're going to have to turn up the gain, but that's going to distort your image. It's not going to be a true, clear, crisp image. Now, there are times when you just, in general, need to turn up the gain when you're evaluating the eye for a vitreous hemorrhage, vitreous detachment versus a retinal detachment. It's always good to turn up your gain. You want it, higher than the average setting. So let's take a look at these two examples. So this first one here is going to be a heart that's got a significant pericardial effusion, but you have a lot of this fluid causing posterior acoustic enhancement. Don't need to do anything about the gain. You have all of this helping you out. Everything's nice and bright. Now, compared to this one on the left, so see how high that gain is turned up? It really makes it hard to distinguish what's going on. Yes, we can tell there's a pericardial effusion, but we need to try other things to make this image a bit more clear. So that may be positioning the patient, that may be adding gel, that may be adding pressure to kind of clear this up rather than adding so much gain. Let's talk about our modes. So the way that ultrasound started out is they would send a single pulsed wave into a tissue, and then that wave was plotted based on the strength or amplitude of the signal when it returned, equating it to the depth of the tissue. So this first point here, had an amplitude that was kind of low, but its depth was very shallow. And then the next wave that it sent down was a little bit higher amplitude and a little bit further down. This next point was much higher amplitude returned and a little bit further in depth. And then so on and so forth, all the way through the depth of this tissue, whatever it is. So this is the most simplest form of ultrasound. A single wave down into a tissue, and it returned back at a certain amplitude over a certain amount of time. So that would be the depth. So with time and as technology's advanced, we developed better ultrasound technology. So rather than a single wave, a single frequency, a single beam being sent, let's do that for hundreds. And let's do it over a larger footprint. So yes, we are sending hundreds of waves down into a tissue. The returning signal intensity, the brighter it is, the more signal is returned, the less attenuation. is returned to the probe. The darker it is, meaning that there's either no return back to the probe. As we can see here, this is a thyroid cartilage. Here's the cricoid cartilage. This is the cricothyroid membrane. So a highly reflective surface. You didn't lose really anything. The signal came down, bounced up very well, and returned back. And we don't really see much back here because this is all air. So most of that reflected up. What we see here is mirror artifact. So very similar to A-lines. So signal came down through this structure. Some of them bounced back. A lot of them hit this bright structure here and came back. Some of the signal got kind of captured in this, and then as it came back up through this tissue later, the machine thought, oh, that must be deeper down because it came back at a later time. But that's why this looks identical to this cricoid ring. You don't have a cricoid ring that goes around the membrane here. That's just artifact. So this is our time, our depth, our distance, and this whole thing is the probe footprint. So use everything to your advantage when you're evaluating an image. Don't just look right here at the center of your screen. Yeah, that's your best focal point, but we want to evaluate everything. Okay, this is a linear probe. That means it's high frequency, low depth. What am I seeing? Well, I see something that's very hyperechoic with clean shadowing behind it. This is a highly reflective surface with some, maybe reverberation artifacts and kind of dirty shadowing consistent with like air. And then, I see something that looks, kind of rounded here and it's reflected back. So yeah, I think this is a highly reflective surface, very similar to the diaphragm or any other fibrous tissue causing artifact. So you can tell a lot by evaluating the whole picture. Do you see anything down here? Do you see a different footprint? Is this probe marker over on this side? So evaluate the entirety of the image. So is there a C mode? Well, no, but there is an M mode. This is, M for motion. The previous B mode that we were talking about sending hundreds of signals from the probe footprint through the tissue. So now we're going to turn on M mode. So rather than evaluating the entirety of the footprint, we only want to evaluate one single line through the tissue. And we can move that anywhere. And depending on where we put it, the machine starts plotting it over time. This is the same structure the entirety of the time that you're evaluating, but it's detecting the motion. So we like to use this for fetal heart rate. We like to use this for the heart when we're looking at EPSS, E-point septal separation, and we just evaluate over time. It's the same concept of how sonography on boats work, the fish finders. It gives you a graphical depiction of the ocean floor below you as you're traveling. So it sends down a single signal and it hits here and it's deeper, and then it hits here and it's not as deep, and then it hits here and it's deeper. So this is showing us what the heart is doing, and it correlates perfectly to your depth over here on the screen. So this big bright structure here with empty ventricle or maybe thoracic lung or pleural effusion behind it is all of this right here. So here's your kind of inferior wall of the heart sitting next to lung tissue or pleural effusion, and then maybe lung tissue or some other dense structure below it. So M mode is just motion, a single line through a structure over time, and you can change how quickly this speed goes. You can change the sweep speed to be faster or slower. If you're really trying to zone in on something that's very fast, you might want to slow it down, like a fetal heart rate. If you have it too fast, it may be hard to really pick out the start of one beat to the start of the next beat. So you can adjust your sweep speed on the machine. All right, so what what happens when the machine gets confused. That's artifact. So it's not really that this is what's going on. It's just what the machine is interpreting. It's only as good as the data being given to it. So just like any machine, good information in gets good information out. So the quality of your image, the footprint of the probe on the patient's chest, the amount of gel that you use. So that's why we always say use more gel, use more pressure. Position the patient to get the heart up against the chest, roll them onto their left side, stretch out their left arm and open up those rib spaces to get more contact with your patient or your organ that you're identifying. But we can use these artifacts to our advantage. Radiopedia has an excellent library of like more than 20 different types of artifacts. We're not going to go over all of them, but I will give you examples of certain ones that you will likely see that are very common. So you know what these are. You know that these are A-lines. You know that we see A-lines when we're looking at the lung. These are reverberation artifact. This occurs when the ultrasound beam hits a highly reflective surface, and the ultrasound waves get stuck in these reflective surfaces and then bounce back at a later time. That's why they're repeating at regular intervals. So here's rib shadow, here's rib shadow, here's the real pleural line, and then you get, these sound waves come down, some of them hit and come back up. That's your first line. Some of them come down and then kind of get stuck for this amount of time, and then they bounce out and come back. And they don't have much loss of signal, so it looks nice and bright, just like this one. And then some of those signals stay in a little bit longer and then come back, or then escape out and hit the probe. And so the probe says, oh, those came back much later, so they must be down here, and so on and so forth. So we can use these to evaluate, the peritoneum is the same way. If you're seeing A-line reverberation artifact in the peritoneum, you're either right up against air-filled bowel on the peritoneum, or they've got a perfect viscus, and they have free air in the belly, because the peritoneum is a highly reflective surface, and you should get reverberation artifact. So if the clinical presentation is a peritonitic abdomen, rebound tenderness, they have a history of diverticulitis, they have a history of arterial disease, and they've had mesenteric ischemia, whether it's acute or chronic, and now they're peritonitic, and you put the probe on their belly and you see this, that should be suspicious. Say, I need to evaluate this really closely. Maybe I'm going to call surgery sooner rather than later, just to get them on board and aware of what's going on. We can use this artifact to our advantage. There's not really anything you can do to avoid this. It's not a bad thing to avoid, but it helps us determine what's going on. We can think a little bit more critically about our differential and expanding it or ruling things out when we see artifacts. All right, again, we know what this is. These are B-lines. We know we're looking at the lung. This is a form of resonance or ring down artifact. The sound waves bounce or resonate between fluid that's trapped around gas bubbles. And this fluid constantly vibrates, it resonates. It's kind of like a drum. When you strike a drum, the whole thing vibrates. And that vibration is what you hear. And depending on the type of wood that you have, some of them are more dense, some of them are softer woods, less dense, and they may ring for a long period of time. Others may ring for a short period of time. So when these sound waves resonate in the gas bubbles, it propagates that signal the entirety of the way down. So to really distinguish, are these B lines, we need depth. Do the B lines go the entirety of our field? If they don't go the entirety of the field, they are not true ring down resonance artifact. This is an indication of density. It's not an indication of pulmonary edema. It can be pulmonary edema, but you'll also see this in interstitial lung disease or pulmonary fibrosis. The lung is more dense, so it will have B lines. So you have to critically think, does my patient have a history of congestive heart failure, left ventricular ejection fraction that is reduced, and they have lower extremity swelling, and they have crackles as I listen to them, put the probe on there. I think this is more pulmonary edema and CHF. But if they have, diminished but clear lung sounds, and they have good squeeze of the heart, they have no lower extremity swelling, well, maybe this is more indicative of ARDS or pulmonary edema, interstitial lung disease. So we can use this as a positive finding that when there's a pneumothorax, you will not have B lines. So if you have B lines, you have effectively ruled out pneumothorax. When you have a dropped lung, you no longer have this interface. You no longer have a lung that is up. You cannot have B lines if you have a pneumothorax. B lines are a good thing to see in a trauma patient. It tells you there's no pneumothorax. I probably got pulmonary contusion. It's likely they're going to go into ARDS. I need to be vigilant about their airway and pulmonary management. So let's talk about some mirror artifact. Just looking at this still image here, you can see that there's, some kind of hyperechoic circular structure here in the, spleen or liver. I'm not exactly sure what this is here. Based on how big it is, I'm guessing liver. But then you have, out of convention, we know, okay, this is towards the head, so this must be the diaphragm. But on the other side of the diaphragm, we have the same circular density, not quite lined up where this is, and it's further down, and you have this line here that looks just like this line here. So, well, what's happening? Well, one sound wave goes down and kind of bounces in between that highly reflective surface. So it hits this once, and some of them bounce back up, and then get stuck in here, and then bounce back up again. So it hits these signals at a later time, and the machine says, oh, well, these signals came back up, and it looks like this intensity, but signals came up later with the same intensity, so it must be down here. Whereas other parts, the sound wave bounces down and back up, so we don't see any kind of mirror image. So whenever we see something on the other side of the diaphragm, we have to be cognizant of, is this really hepatization of the lung? Does it fit the clinical picture? Or does it mimic these same structures almost perfectly, and that's just mirror artifact? So you can't just assume that, oh yeah, this is, a pleural fusion, and that's hepatization of the lung. That's pneumonia. So think critically. Okay, this all looks the same. So signals, sound waves, just got trapped here momentarily, bounced back up through this at a later time. So the machine says, oh yeah, that's down here. It's not. It's just an artifact. It's confused. That's okay. So we talked earlier about the ultrasound beam width. So we can get beam width artifact when reflective objects are located kind of beyond the widened ultrasound beam after the focal zone. And this creates a false detectable echo that's displayed as like overlapping structures of interest. So, our focal point here is right here. So beyond that focal point, you're going to have these, other aberrant waves or beams that will detect things, and the machine says, well, it's in the center, it's where it should be, and it comes back at a later time or at the same time, so it's here. You'll often see this when you have a lot of depth and the beam is not uniform in depth with the main beam, as especially things that are like kind of beyond the focal zone, like kind of distal to that. So this is a patient that we scanned recently, a gallbladder from a posterior view. So looking from posterior to anterior, we have a lot more depth here than we normally would. And just watch as we play through this clip. Usually when you're scanning an anechoic structure like the gallbladder or like the bladder itself, you may see things beyond the structure out to the sides. Like in the gallbladder, we have the duodenum that sits out here, and you'll see gas bubbles in that. And they mimic stones within the gallbladder, because the machine is assuming that what's out here should be right here in the center. So we're gonna play this video. So, it looks relatively clear when we play it. But it's let's take a look at the next one and see how it looks. So same gallbladder, just a little bit different position. We rotated the probe. And notice the focal point, is here, and the gallbladder is kind of beyond that. Now as we scan through, we kind of see some haziness inside the gallbladder that's not consistently throughout. So maybe that's some side lobe or beam width artifact that the machine is saying, well, it's here in the center, let's put it there in the center of the gallbladder. So now we're going to compare from an anterior approach. Patient didn't have as good of windows from an anterior approach, but here's gallbladder here in a much closer field, our focal point being here, so we should be, in a good spot to reduce that beam width artifact. So looking here, it's like, well, we still get, sometimes it looks totally anechoic, and other times it looks like there's sludge on one side, but it doesn't make sense why there would be sludge on one side. So let's take a look at a different view. So we rotated the probe so we can get more of a short axis. Now let's see if we see the same findings, or does it look different? Again, our focal zone is here, our focal point is here, so we shouldn't be beyond that. And looking through, it looks kind of all dense, but it looks very much like the liver here. So we're going to take one final view, and just starting again, we can see how the anechoic area here versus the more homogeneous echo here on this side. Let's see if it continues. It kind of shares a lot of the same echo texture as here. So it looks like it doesn't have a continuous homogeneous echo to look like sludge. To me, this looks more like this same structure out here, which in this view would be duodenum. So I think this is more just a normal gallbladder with beam width artifact. So this is just a still image, but it depicts two very important concepts that we see all the time, and we should be using our critical thinking skills to identify what's going on. So it's a gallbladder. We have our liver here. Here's the anterior wall sitting up against the gallbladder, and our posterior wall sitting down here. This is a nice anechoic structure. It looks a little bit dilated, and behind it we have posterior acoustic enhancement. This is what allows us to evaluate the uterus and pregnancies in a transabdominal view through the bladder. We like a nice filled bladder. It helps brighten up, and we don't lose any of the signal of the ultrasound when we have to go to deeper structures. So this is all very bright back here. So a couple of things we have to keep in mind. We never measure the posterior wall of the gallbladder because this is falsely enlarged. We want to measure the anterior wall that abuts the liver, because this is all going to be falsely elevated. If we track the gallbladder here to the neck, so fundus, body, and neck, we can see that there's this area of tissue here that, is a little bit hyperechoic, but there's no shadowing behind it. And then we get to this bright hyperechoic arc here with nice clean shadowing behind it. Anything that is very bright and echogenic, that means all those signals are hitting and bouncing back. And the machine says, well, I didn't hear anything later, so this must all be black behind it. This is a stone. So this is a stone in the neck of the gallbladder. It's not like a common bile duct. It's not dilated. This is just a single stone that's causing posterior acoustic shadowing, just like our bone cortex does, but it's sitting in a obstructive place in the gallbladder. Right, home stretch, I promise. 41 out of 45. So not all images are, or not all dense structures or dense objects cast a shadow. However, acoustic impedance helps us identify dense objects. So there is a artifact called comet tail artifact that help us identify when there's like small calcifications or crystalline or highly reflective objects, like the tip of our needle when we're doing a central line or peripheral line. And it's a kind of a special form of reverberation artifact. It's similar to the like a comet tail. The times when we'll see these are like small renal or ureteric calculi. Small bile duct stones may cast a little bit of a small comet tail. When we see this in the gallbladder, especially on the anterior walls, and they don't extend all the way through, we should think of adenomyomatosis of the gallbladder. You may see them as like microlithiasis in the testicles, surgical clips, catheter tips, debris, glass, metal, and other things. So let's take a look at this cardiac view. Do you see anything that looks out of place or abnormal? So just a small 6-second clip. We'll evaluate a little bit further with other techniques. So these are still images where I threw on a color box to evaluate something here in the right apical myocardium. So it's highly reflective and has a small comet tail artifact behind it. So it must be dense, but it's not big enough to cause shadowing behind it. In this single clip, it's bright white. There's no color to it. It's going to be hard to see, but once the incination angle is less than 60 degrees, we can see that it brights up with color. So it's going to be that aliasing red, blue, like strong white, yellow colors. So this means that the incinating beam vibrates that object, and so it's very high frequencies that are returned or that the probe can sense. So it doesn't know what the velocity is. It just says, whoa, that's way too bright. I'm going to light it up with everything that that I can. So this object here was a dense piece of shrapnel from a gunshot wound. It was just hanging out in the myocardium. He had a small pericardial effusion, but there was no evidence of tamponade. So again, let's use our artifacts to our advantage. I'm going to play this clip, and I want you to just evaluate it. It's only a 6-second clip, and see if you notice anything abnormal. You see anything abnormal? Let's go on to the next clip and see. So I threw on a color Doppler box to evaluate if this was something that created a twinkle artifact to show that it's dense structure and not just other fatty soft tissue in the like kind of renal pyramid. So we can see here we have this bright area that encircles the hyperechoic structure here, and we saw the regular blood flow, in nice reds and blues. So, blue away from the probe, red towards the probe. So this is arterial flow, and this is venous drainage. And then around this hyperdense structure, we got that twinkling of aliasing to say, yeah, that's a stone. That's something that is very dense. It's not mobile, and it's just hanging out in the kidney. That's a kidney stone. So here's that same kidney stone, just captured as a still image, where we have all these bright yellows, reds, blues. It doesn't have a direction. It doesn't have a constant red or constant blue or anything. It's this aliasing. It can't determine the velocity of the signals returning from it because of the acoustic impedance of that structure. Okay, that's it. That's the journey of comprehensive ultrasound physics. There's still a lot that you can dive into and really dig deep and understand these concepts a little bit further. But if you want to be a proficient, physician sonographer, you need to understand these concepts, because it's not just straightforward. Oh, that's a kidney, or oh, yep, there's free fluid in the abdomen. You're gonna get cases when you're like, what is that? I don't really know. So let me look around and see what's going on around it. Is it causing any shadows? Do I think this looks like the neighboring structures? Could this be side lobe artifact? Could this be beam width artifact? Is this structure dense? Maybe I need to throw color flow on and adjust my angle of inclination to get it to an angle less than 60 degrees. I'm not seeing flow through this artery in this person's leg. Are they having an acute limb ischemia? Maybe I just need to adjust my angle of inclination. Maybe I need to beam steer. Maybe I need to do other things. Or I'm not seeing the structures that I want to. Maybe I need more gel. Maybe I need more pressure. Maybe I need to move the patient and position them differently. Rather than looking in this standard view, maybe I can come around posteriorly and look through their muscles and not their stomach gas. Try things out. You know the basics. Now take it a step further. Adjust your settings, adjust your gain, your depth, your focal point. Adjust your time gain compensation, adjust your frequency, penetration, or other things of your probe. Try different probes. If you're looking for motion, choose your phased array probe. That's higher frames per second, looking for motion. If not, choose your curvilinear probe. You're going to get the best resolution and wide angle lens to identify structures that may be superficial, or you may need extra penetration with a lower frequency beam to identify deeper structures. Any questions, feel free to reach out to me at any time. You have my contact number. Happy to take a look at any scans. If you're doing them in real time, if you want to review afterwards, give me the clinical context. What were you looking for? What do you think it is? What did you do about it? Always look up the formal imaging. Look up the cardiology performed echo images. Pull up the CT scans and correlate it with what you were looking through, what you were looking for, and see if you can glean any more information from those other sources. In the end, it's only going to make you a better physician, and you're going to have a better critical thinking skills and be able to make clinical decisions with a lot more information than just, I'm going to send them off to CT. Well, not everybody needs a CT. History of kidney stones, they've got hematuria, I look at their kidney, they've got hydro. All right, it looks infected, hydrostone. All right, they need a CT scan because urology is going to want it. History of kidney stones, pain, history sounds like it. They're writhing on the bed. Their urine sample is, gross hematuria. You take a look, there's no hydro. Okay, we can give them pain meds. We can discharge them. We can save them a CT scan. They're on their way. Better patient satisfaction, less radiation, quicker time to dispo, opening up a bed. A lot of great things that you can do with ultrasound that we think about and we teach you. But now it's the application once you're done and no longer in this setting. When I go down to Venice, I grab the ultrasound a lot because I can dispo patients a lot faster with my diagnosis with ultrasound and say, nothing on their history, nothing in their physical, their labs all look good. They don't need a CT scan because they don't have a peritonitic belly. They don't have fevers. They don't have an infection of unknown source. Like, I can treat them appropriately, safely discharge them, and get follow-up arranged for them and free up a bed rather than transferring out of the hospital that's full of patients. It's better for the patients. It's better for healthcare. It makes you a better physician, and it'll show when your patients are asking you questions. You will sound way smarter than you may actually be. And I only speak from experience because I was just a basic firefighter that liked knowing my job at the very basic level, and that's what I do in emergency medicine. I do it in a very fundamental way. ABCs, are their vitals stable? Can I ultrasound to get a disposition? Do they really need additional imaging? I don't care what the patient wants. I don't care what the patient expects. I talk with them about those things. What are your expectations of today's visit? If it sounds like it's going to be a difficult encounter, I bring that up right away. And I can say, we can do an ultrasound. I can show you all the images, and I can explain my rationale for why everything looks normal. And you're safe to go home, and they can see it right there. It's not this vague, well, I went to a donut, it scanned me quickly, it took like 2 hours to get back, and you're saying nothing's wrong with me? I didn't see anything, I didn't hear anything. Like, what's going on? You can use ultrasound right there at the bedside and say, here's your liver, here's your kidney, everything looks great. Or you can say, ooh, I don't like this. And in the setting of your labs, in the setting of your fever, I need to do more for you to get you the right care that you need. Patients like that. It's better patient care. It's smart doctors. It's good clinical medicine.